Okay, so two main things. We don't have many slides, and we don't have a ton of data to share. This is really hopefully going to be more conversational and prompt ideas for what can happen with some of these card screening data. We're going to talk about the peer review process, and Tracy will describe more about what that means and what that looks like, and then we'll talk a little bit about what their current data set looks like for the, what they call the card screening cohort, the lung cancer screening cohort being a subset of that, but even that's not quite correct. So in any case, so Tracy's going to first start out soft by talking about this, and apologies.
It's on that poster over there.
If you want to see the actual data, yeah.
So I think this is from 2016.
You can still describe it, I think.
Yeah. So at that point we had 3,000 some odd chest x-rays. And so every chest x-ray we do through our asbestos health screening program, we send out to a B reader. Jaime's one of our B readers. We have 4 other ones. So we have this team. 3 of the B readers are also thoracic radiologists who read our CTs. So every CT scan we do, which at that point we had done 2,491, every CT scan also goes out to one of those outside readers, the 3 that are thoracic radiologists. So they read them. Dr. Black reads them as well, and they're also read by a local radiologist. So we have lots and lots of reads. We don't usually pay attention to the local radiologist read. We basically use Dr. Black's, and the outside reads are used to get people benefits if we didn't diagnose the person, but the outside readers say, oh, this looks like asbestos disease. They still have access to that Medicare and pilot benefits that I had talked about earlier.
Yeah, and so part of their ATSDR screening grant is to also do this peer review process, which is what Tracy can kind of explain. Maybe you can explain sort of how that goes.
Pat, you have a question?
Can I just have a quick question? So the local radiologist, do they give a report, and do the participants get multiple reports?
The participants don't get the report, they just get a results letter.
Like a result, yeah. So, I mean, do they conflict?
So the local, yeah, there is some confusion, and that's why we don't usually use the local radiologist. The idea of the local radiologist is if there's a major problem, if there's something that's medically important right now, then they call us and we call the patient right away to deal with it. That's the only reason why we have to do that, because these outside reads take sometimes a month or 2 to get back.
Right.
So that's a screening read for like a cancer or something like that.
Yeah.
So each person that gets, a chest x-ray or CT gets read by the local read, by Brad, and by an outside
That is correct.
person.
So I guess, so they get 3 results letters?
Nope, 1 result letter.
1 result.
So card is basically the final answer.
Okay.
And those outside reads don't come back until after we sent that results letter. And so remember, this is just for the asbestos screening. The lung cancer screening is different. We wait for the LCAP read. So if we say, oh, you don't have any disease, but that outside read comes back and they say, oh, this looks like asbestos disease, we have to honor that even if we know the whole patient's story. So we know they got in some car wreck and that's why they have this scarring, but the outside reader said, well, that looks like asbestos. We still have to call the patient and go, we don't think you have clinical asbestos-related disease. We're not diagnosing you at card. However, you still have access to Medicare and the pilot program because of this read. And that's just in the way the law is written.
Probably pretty infrequent.
It's not infrequent, really, no. We have a person whose job it is to do that. She probably does 4 or 5 a week.
So part of the requirements of the screening program, no, this is good. Part of the requirements of the screening program is that they also do this peer review process, which is pretty time intensive and and involves all 5 B readers and all 3 CT readers.
Yep, and so the B readers are the same as the CT readers. It's 5 people, so 2 of them just get chest x-rays, the other 3 get chest x-rays and CT scans. So twice a year we send out 24 CTs and 54 x-rays to all of the readers. And then we get their results back. I send them to Curtis.
But isn't there an intermediate step too? Don't you have a phone call or something?
After you get your results to us.
All right, got it. All right.
So I send them to Curtis, he kind of interprets them, and then we get on the phone with all 5 readers and we go through each time that they didn't completely agree, which is basically every image that's not all negative.
And just to be clear,
Right,
I'm not interpreting them in the way you're thinking. I'm just evaluating agreement. is
Sorry,
all.
yes.
So from Tracy, I just get the yeses and nos,
Yes.
right? And so we're just looking at simple agreement.
Thumbs up, thumbs down.
Right. And this is just looking, so they've done it twice per year for 7 years. And this is where, perfect timing, David, I'm glad you walked in here, because this is the data set that I think would be really interesting to see how the automated read of this CT, this is the chest x-ray, so maybe that's not relevant. Let's just jump to the CT stuff.
What are the graphs?
Yeah, so this is just looking at a kappa, right? Agreement with standard error over these, different peer review. Each peer review is how many for CT?
24.
24 for CT. These orange bars are just indicating, how much, in this case, percent positive by one or more readers, okay? So just kind of giving an indication of, how many were indicated as positive by one of the 3 readers. But in any case, this might be a good data set to see, how the automated interpretation holds up against the B read and the CT read data, since it's already been done by these external readers.
And we also have Dr. Black's read on all of these, which isn't in this peer review set.
Right.
How did you choose the 24? Are they random?
It's just, whoever comes through first, it's by quarter or by the year. So the first time we end up with 24 CT scans, the readers have requested that it's people that we have a chest x-ray on, which is almost everybody, because the chest x-ray is required, but some people just refuse to do it. So it's got to be somebody we have a chest x-ray on so they can look at the chest x-ray and the CT.
And it's sequential in how they show up.
Yep.
Right.
And then we just,
That's pretty poor agreement.
Right.
yes, it is.
I mean, well, compared to, so if you start with the chest x-ray, it looks like this is really poor, and the CT is at least a little bit better.
We agree
But-
with the chest x-ray.
And so it's anywhere between 0.4 and 0.6.
I should add in that there's a great agreement if it's a random selection. So it's not completely a random selection. We did that probably 2 years ago, I think, because the reader said, well, you can't send us all negative ones. We're
Right.
always going to agree.
Right. So that's why I kind of added this right-hand, bar, just to try and indicate how many of the reads were positive.
Do they have standards, though, that they look at? Have they agreed on standards before they do these?
Well, there's a whole chapter out of the book for the CT reading. We use, help me out here, I know you know. We use, ATSDR gave it to us. We use a form for the CTs, and there's a whole chapter out of a book that gives you directions on how to read it.
And you think they've read it?
Well, I don't know if they've read it, but I certainly sent it to them and asked them to follow those
Yeah.
directions.
It's hard. That's a really good question. I think one of the things that you might expect over time, because it's the same 3 people over 7 years,
Yep.
and they have these phone calls where they discuss some of the disagreements. So you'd think that this would get much better, but and I guess you could say maybe it's gotten a little better, but not tremendously so.
Not for parenchyma.
Not for parenchymal, no.
Personal observation,
Yeah.
what tends to happen is, I sat on these sessions when we're part of the participants, and there's this discussion, and there's obviously a lot of disagreement. Eventually, all kind of, the stronger reader tends to influence the other readers to go the direction what they see.
The stronger
So-
personality
and
reader, yes.
It's really come down to where they almost have to have calcification before they'll even step out there, and so it's really difficult to watch. You'd think it'd get better, but then they go back and do it the way they did. They've always done it, and the next session, they go through the same thing, don't they? I mean, it's just like,
And so the CT agreement kind of has increased and gotten better, but it doesn't really meet CARD's needs in the sense that what they're agreeing on is only calcified things. If there's calcification, we're going to call it.
Right. So this is not capturing anything with respect to lamellar thickening that we've been talking about. So in that sense, I'm not sure how many of the 24 you select have that feature.
We're selecting everybody that CARD has read positive. So every one of these, we
Oh.
have read positive. And that,
All right,
like I
so
said, that
that's-
happened a couple of years ago when the readers started saying, well, of course we're going to agree they're all negative.
So CARD read every one of those positive, but they're reading them at somewhere around 30% positive?
Yeah, in the case of, anywhere, well, it varies, right? But,
Right,
Whatever-
depending on.
yeah, and that's just one.
But
that's
remember, we
just
read
one of the
either
CT
or
readers.
positive. We read either plural or parenchymal. Usually it's plural, but not always. And we're looking at them separately right now.
Oh, I see, right. So it's the same 24, right, obviously. And,
Yeah.
and the 24 you select might have parenchymal or plural according to CARD.
Right.
And then you send them for review.
Yeah, and they might have plural and parenchymal or plural or parenchymal based on these outside reads, right? So I can't tell you it's 30% exactly is what I'm saying.
Right.
Does that make sense?
So anyway, I think there's something that could be done with this that would be more helpful for, this peer review process moving forward. But I don't know what it is,
Right. Which is why I really think the idea of putting these data into a system that says, oh yeah, I can see lamellar pleural thickening or something would really help, because that's the thing we've been fighting for years, is that we're seeing this different kind of disease and these readers are reading the Mount Sinai disease, the big chunky plaques.
Right.
And that's where the disconnect lies.
And Brad, do you know, are the CT readers looking at only the mediastinal window, or are they, what are they doing?
I don't know, they vary.
Jaime knows.
Some
I
use,
think.
I know one of them uses the mediastinal windows to determine if it's pleural disease. And of course, most of Libby's disappears. Well, we know, David and I have discussed this.
Right.
And there's no basis
They
for
get the
using
full-
mediastinal windows other than it's just been traditionally done by radiologists. So nobody, now that we're looking at a disease state, people they don't know about
Right.
what they're looking for. It's like who is it? The radiologist wrote that article on the hinterland. What's abnormal? In every radiologist, abnormality is different, right? Would that be what you see, David and Claudia? That's why there's variation in the human eye, and the knowledge of what disease states might be there are highly variable.
Mm-hmm.
And so you don't get a congruence on what really is abnormal, and
Right.
it's really difficult.
Well, what CARD has done in the last couple of years, this is, wasn't in place during LERP or Chiefs or these other studies, is that you've got this really great electronic medical records relational database system now.
Yes.
It's totally like a new.
Dr. Black would disagree with you about the really great
Well,
part, but
yeah, but it's better than what you had, right?
Way better,
I mean,
yes.
so there's something to be done with these data now, and so this is just looking at this particular population of the screening, just first visit. I just put down 48% female. I think we should always remember that, this is one of the unique features of an asbestos exposed population. It's not singularly unique, but it's a pretty key feature of your cohort here. Tend to be older, but this also includes, I don't know if it includes 100% of the Chiefs kids, but they're
No.
not in this group? Okay.
No.
They could be though.
they could be.
might
There's
be.
a few
They
of them
might
that
be.
are, I'm sure, but
Right.
The eligibility criteria again were they had to live here for more than 6 months 10 years ago.
yep, at least 6 months, at least 10 years ago.
Okay.
So they would all qualify, but many of them haven't gone through.
10
The
years
Chiefs.
from the present date or 10 years from
Yes.
1990?
10 years from right now.
Oh, wow.
So
Okay.
I will officially be eligible for screening like next month because I've been here for 10 years.
Okay. All right. So you're going to start accruing like
Rolling like-
unexposed,
You're going to start.
yeah,
rolling
unexposed
like-
people. Yeah. That's cool.
That's really cool.
Yeah. Smoking is about what maybe a little higher than Montana general population.
Actually, we're
But-
lower. I think Montana
Really?
general population, last time I reported was at 21 or
Oh,
23.
okay. All right. Quite a lot that are overweight / obese according to BMI. So this is a pretty at-risk population for a lot of things, and that's just keep that thought in mind. And so this is from the initial screening visit, and they do have repeat measures on some of these people, but from the initial screening visit, 69% with respiratory symptom at the date of the screening, 26% with abnormal spirometry, which could be a variety of things,
Right.
47% with one or more autoimmune symptoms,
And that's based on Dr. Deagle created us this checklist of autoimmune symptoms that we ask people.
and then 46% with ARD. And this is one of the trickiest pieces for me. Like, what does that mean? You know, basically, it's the like whether or not card designates that person as having a specialist-related disease according to either the external read or Brad's read or, well, I guess that's it.
That's it, yep.
One of those things.
So
Right.
is this by
Wow.
patient? So
Yeah, this is
if you
just,
go into the screening program,
Still.
you leave the screening program and don't go back again if you get diagnosed.
Wrong number.
And so if you come back for a second or third or fourth screening, you're not being counted in the,
right. This is just their
It's per
first screen,
patient.
this is just first screening visit. Like if we looked at more prospectively, at their first visit.
What are we saying?
Right. So some of these, you know, have now cycled through. You know, if they were screened with no ARD, right, then then you follow up with them 5 years later.
1, 3, or 5, depending on their
One-
symptoms. And,
Yeah.
Okay, so if they have no ARD, no symptoms, they probably come back in 5 years.
right.
So you can calculate incidence then.
Right.
Yeah.
Right. Among the 54%
Yeah.
that were
Which is a
ARD free.
big number because of the overall number.
Yeah. Right.
That's pretty cool.
You could also, also of interest might be whether they remain smokers and whether they remain overweight.
We
And-
do actually report whether they remain smokers. We don't report whether they remain
Because
overweight.
that is that it's not ARD, but it's also a benefit to the community
Yeah.
of the screening, and probably quite a great one where it reduces risk.
Right.
That's a really good point.
Right. Yeah, and I have more on that later, Ted. I think that you're hitting upon something that I think is really key for something to do next,
The
right?
public
And
prevention.
Right. Okay, so this is just, how much time do we have, Dean? Because this is just open floor. I'm just going to put some prompts out for, did you have a question, Pat?
Do you have biospecimens on them? Blood, urine, things like that?
We don't have much urine. We have urine from the community probably from 2008 that we've kept. Since then, we've only been drawing blood. We have
So you do have blood, serum, whole, what?
we have serum and we have plasma and we have Buffy coat, and I think they're all separated out. Right, Jean? Thank you. But not on everybody.
And not urine.
And moving forward, if this ANA gets approved, it's going to decrease pretty dramatically because we're already sending them for a blood draw, so they're not going to be doing another one when they get over to card. But we did talk yesterday about maybe card should be doing that blood draw and sending it out to PAML, in which case then we'd have more.
Yeah.
And then
So
you
that
can-
is something
well,
we
you
can
may
look
not be able
into.
to burn a whole sample, yeah, and, type
Yeah,
your sample.
take another shift or two,
Right.
yeah.
But that might protect samples.
Go ahead.
No, I was just thinking of bigger, you should
Yeah,
go,
okay.
big opportunities with
Um,
this type of, even beyond asbestos.
Yeah,
Right.
totally. So this is something that we've talked about a lot over the last day and a half is just, you know, is there, you know, as Ted indicated, maybe there's 3 groups of patients, maybe there's more. And how do you, like, what are the features of this discordance between like a card ARD diagnosis and the external reads? I think we all kind of recognize that if someone's just looking at an image and not looking at all the other information about the patient, it's pretty clear why they might not see something that's there, but there's other reasons they might not see something that's there if they're not using the right windows or whatnot. We could, you know, we did kind of look at that discordance as Tracy was preparing her screening reapplication. You didn't put this in there,
I did not.
hope. Anyway, but just sort of back of the envelope looking at what are the characteristics of a patient that's indicated as, you know, positive ARD by card, but negative by the outside reader. It's not BMI. It's not smoking. It's, or at least I shouldn't say it's not. It's those 2 things are not associated with that discordance. Presence of autoimmune symptoms might be. There is some evidence that people with autoimmune symptoms are more likely to be diagnosed by card as having ARD and not diagnosed by the outside reader as having ARD. And then age has something to play with it. So there's some things more we could tease out about that, maybe look deeper into the database and figure out what the important features are, if that's of interest or useful. I'm not sure
I mean, I
if it
think
is.
to be proactive, like Ted's been saying, it's very interesting.
Right.
Do you have a feel for what the delta is between positive followed by the card and pure negative across?
Yeah, I could show you a table later on. It's pretty high. It's pretty high. And then
Good, Pat?
They do a
Sorry.
big questionnaire too, right?
Yes.
In enrollment, same
Yep.
type of thing that we've done in LERP and.
right. They do a big questionnaire. So that's another area I don't have it indicated as one of these bullet points, but getting some way that the exposure data, they collect tons of exposure data. It'd be nice to have that like immediately available at the clinic, right?
Yeah.
We were talking when you were.
We came so close to doing something really exciting, we never did it.
Yeah, that company that was putting in their medical records program, I said, well, here's what you should do. And I don't know, it
not
was
Epic?
too much for
It's
them.
not Epic?
No, we have Next Gen.
Next gen.
We got Next Gen specifically so we can put in all of these questionnaires and
Right.
everything, because we could customize it and keep it on site instead of in the cloud.
But maybe it's better that they didn't do that, because I was pushing them to do it sort of the other prior way we had done it. I think using Pat and Carol's scheme would be better if that was doable.
And then potential new exposure data from the ARP database too.
So each individual would then have that quantified kind of estimation based on their reports on the questionnaire.
Yeah,
Yeah.
I mean,
That would be nice to have.
it would be great for
Yeah,
like
that'd be-
Brad to be able to look at, oh, you're like, in the
Set
in
that
the
up.
76th percentile of environmental exposure or something.
Based
right?
on everybody in our whole
Quantification.
database.
Right.
You could set that up automatically in RedCap or something.
Yeah, that would be very doable.
Ted had mentioned something like this, like machine learning. I think, we know it's more than just looking at the CT read, of course. And if there was a way that we could interrogate the clinical notes, like if there's something in there about, lamellar thickening or something, maybe there's, that's easier said than done, I think, that kind of stuff. But maybe there's an opportunity there. I don't know if
Have you
anyone-
looked into natural language processing and things like that?
Yeah, something like that, right? I don't have familiarity with that.
We haven't looked into it, no,
There's
but
some in vivos and things like that. I mean, they're very good.
Yeah. Actually,
And then this is sort of another $1 million question, of course, right? What are the radiological, immunological, and symptomatic characteristics that are predictive of decreased lung function? You'd think we'd be able to figure that out with all this data that's here, right? I think the ANA stuff that, Gene and Tracy are going to start to capture, maybe that'll help down the road. I think more information on the radiological findings would be useful. Like right now, it just says they've got pleural changes or not in that database, right? It doesn't say what kind
right.
of pleural change there are. Maybe there's a reason for that.
There's just a lot of data entries.
Right, it's a lot of data, right? And then how do you score that, or do you use the the eco ERD form or not, or So you're right. There's more difficulty with that. So this came up yesterday. What about all these other conditions, right? That may or may not be related to asbestos exposure. I mean, in my view, it doesn't really matter if it does or not, if it's related. But do you collect, for example, in this screening population, other health data?
Self-reported.
Self-reported. Okay.
In the screening population for lung cancer screening, the LCAP reports come with coronary artery calcification scores, which is nice.
So here's the thing that I was kind of alluding to earlier, right? Everything that we're talking about with respect to the screening program, I mean, screening by definition is secondary prevention, right? I mean, it's part of that sort of disease prevention paradigm. But the sister to that, of course, is health promotion, and this cohort would be, a rich opportunity for deploying evidence-based health promotion, programs, whether it be the diabetes prevention program or something that's more focused on heart health. There's
Or obesity.
right.
And for government agencies and the like, here you have an inbuilt population with data and things. I mean, it's got to be very attractive for additional funding for things, you would think.
Yeah, you would
Or
think.
like,
Health promotion
You know, add to
activities do
this
get
and-
funding from different agencies.
Yeah.
so
Right.
that health
And-
promotion
and really
agencies
would
funding
help the
source.
people. that
Certainly
live
is, right. And since these are Medicare population, at least those with ARD, I would think that some of that kind of activity would be reimbursable, right? Particularly the evidence-based programs.
Well, smoking cessation you could certainly put in.
Yes, smoking cessation, right.
Yeah, I mean, we already have to provide free smoking cessation because it's a grant.
So a bullet point that I don't have in here, which I think is really important, and I'm sorry that I'm going to miss your talk later, Ted, but the whole community piece that came up yesterday afternoon too. I mean, there's so much that could be done on that.
Yeah,
And I think the resources that you have within the screening program to do that, it only scratches the surface, right? Your outreach budget for that is limited, I
yeah,
assume.
it is.
Right. So there's a lot more that could be done on that in the context of grants or anything. And then you want to
Mortality
talk about
follow-up.
mortality
Yeah, I
follow-up. We already
talked
talked
about
about
it.
that a little bit. Yeah. Yeah. So, I don't know. This is just a lot of food for thought. This is all we really had to talk about.
Yep.